Coffee and Conversations. This month, our topic is being presented by our guest speaker, Mr. Thomas Mitchell, who is the Executive Director of the Children's Hope House in Covington, the Children's Advocacy Center. And on behalf of the Executive Director, Dr. Miss Ursula Anderson, I want to welcome everybody. If you have questions today, please place them in the Q&A. We will get to all questions at the end of the workshop today. So, also, this meeting is being recorded for training purposes. And if we don't get to your question that you put in the chat box or the Q&A today, we will get the answer from Thomas and email the answers to questions that don't get answered at a later date. So I want to welcome everybody and introduce you to Thomas Mitchell, and he's going to take over from here.
Excellent. Thank you, Sharon. And it's a pleasure to be with all of you. Thanks for joining our coffee and conversations. I hope that within the next hour, you're going to gain some really pragmatic, practical skills to ensure that trauma-informed care practices are respected and appreciated and implemented within your environments and where you work, whether that be healthcare settings, judicial outlets such as courtrooms or prosecution or family law, or schools or churches. Trauma-informed care is often a buzzword that we hear around, but it certainly implies that we're going to do everything we can to meet the unique needs of the children who have been through experiences such as traumatic events. So I'm going to go ahead and start sharing my PowerPoint, and I want to make sure everybody can see it and good to go, and we should be fine. So
Looks good.
great. Thank you. So again, like Sharon mentioned, at the end of our call today, we'll have some time for Q&A, but if you have any question, I'll also try to get to that following this presentation if I can't get to it today. But certainly I'll try to reserve, space at the end where we can go through some of your questions. About me, I've been the director of Hope House, which is a children's advocacy center. It's a really phenomenal place for healing and hope and getting justice for kids who have experienced criminal victimization performed against them. So oftentimes we're working with children who are victims of sexual abuse, physical abuse, trafficking, any type of crime that has been committed against the child. This year, we had 500 children walk through our doors for the first time, and we facilitate forensic interviewing, counseling services, and it's a very trauma-informed environment to help them feel safe. I'm a TBRI. If a lot of what you see and hear today is going to be based on TBRI, which is trust-based relational interventions. It was developed at TCU by Doctors Karen Purvis and David Cross. I highly encourage you to look that up. It's a really strong model that teaches environmental variables to increase felt safety, that component that'll be at the forefront of what we talk about today. And then that's me in New Orleans for Mardi Gras with my awesome family. We live in Mandeville. But I serve the whole state through a variety of board memberships. I'm on the board for the Louisiana Commission on Law Enforcement Victim Services Advisory, and also Our Lady of the Angels Hospital. And I take a lot of pride in promoting being able to help children recover from trauma. That's the Hope House. So you can imagine if the average age of the kids we serve is 9 years old. So you can imagine if you were a 9-year-old the difference between being taken to a police station to talk about your trauma versus a children's advocacy center. We've been here for 30 years. However, in 1993, if you were a crime victim, 9-year-old Billy, you would actually be taken to Covington Police Department or the sheriff's office. So certainly not a trauma-informed environment in that old system. But our system now, there's over 1,100 children's advocacy centers throughout the nation, each designed to help kids feel safe in a calm, neutral environment. So again, when law enforcement are investigating crimes against children, they bring those kids to our children's advocacy center. So I'd like to start out just if you can think and just digest these questions introspectively, how do you create a safe and supporting environment for children who have experienced trauma where you are in whatever system that you're employed in or you work in? It could be your home. If you've fostered children who have been through trauma, or you're adopting a child who's been through trauma, how can you create a safe and supporting environment? What proactive steps can you take to ensure that children experience something called felt safety and trust within our environment? Felt safety is the cornerstone for the child's ability to recover, to heal, and to no longer experience symptoms associated with PTSD or trauma-related disorders. If a youth doesn't feel safe, and understand their body feeling safe, then trauma recovery is pretty far-fetched. It's very difficult. And a lot of the times what we get into is we know that kids are safe, but they don't know they're safe intrinsically. Cognitively, they might, but physically, they're still at that place. We have kids that come in, and sometimes they're actually in that startle response, or they're in a hypervigilant response, or they're dissociating, they're in that active traumatization. So it's our job to create an environment rich in felt safety. And that's through connection and environment variables that we'll discuss today. So first, trauma-informed care, right? So you hear it all the time, trauma-informed this, trauma-informed that. I think you have to really look at the connection of informed. To create a trauma-informed space is to create information sharing and a fully knowledgeable staff or fully knowledgeable individual group that's serving the child. And that's what I start out with any trauma-informed care presentation, is not going straight to creating teddy bears or snacks or hydration first. It's actually creating an understanding of trauma and being able to view behaviors through a lens of not what's wrong with you, but what happened to you. And what is this behavioral pattern saying about the need behind the behavior? It's kind of like I work with so many agencies or parents or partners that we work with, and it's always right. Like I have a 12-year-old who's experiencing psychosis and aggressive, and it's fighting and spitting and cussing at me, and they're just a bad kid, and there's no hope, and we have to completely reframe that into what is that aggression saying about the need that is the child is expressing, because behind every behavioral pattern there's a need that needs to be met in order for the child to feel safe and feel homeostasis. If you show me a child that's aggressive, I'm going to show you a child that's afraid. Behind almost every aggressive behavior I see in children is a fear-based response. And of course, understanding all of these is critical for us in creating a trauma-informed space. So types of trauma, there's really 3 different components that you could classify traumatization in. One is acute trauma. That could be a single, sudden, usually unexpected event. It could be a bad car accident. It could be the Causeway wreck. I don't know if anyone saw that 50-car pileup yesterday on the causeway, that could be an acute trauma, one event that threatens one's physical, emotional, or sexual health. Um, Chronic trauma would be repeated incidents. So that would be over the course of a week, you experience 3 car wrecks on the causeway, as an innocuous example. It could be just repeated experiences of traumatization over the course of 6 months or a year. Complex developmental trauma is different. Complex, it's not to be confused with complex PTSD. That's not yet been adopted by the DSM, but complex developmental trauma is exposure to multiple or prolonged traumatic events, and the impact of that experience is absorbed in the development of the youth. So you experience sexual abuse at 4 years old, physical abuse at 6 years old, domestic violence at 8 years old. You experience the death of your mother due to drug overdose at 10. You're placed in foster care at 11. You're kicked out of foster care. That would be a very classic example of complex developmental trauma, and it results in a lot of challenges with very high levels of PTSD with an intensity, frequency, and duration, often in the severe or extreme range. And that's most often the kids that we work with at Hope House. We have 500 kids that walk in through our doors, this year, but we take the most serious cases, about a 150 to 200, for routing and trauma-focused therapy here on site. So a lot of the times, like I mentioned, with partners and agencies, they're coming to you with symptoms and challenges, that, this kid's acting up in class. He's not a good kid. Every time I try to talk to him, he's cusses me out, and he's unruly. He's checking out, not paying attention to me, all of these symptoms. And very little of the time, we get calls from teachers and educators very frequently, and we're missing the rest of the story, and what happened to that youth that contributes now to these symptoms or behavioral patterns, such as dissociation, hypervigilance, hyperarousal. Being in that chronic fight, flight, or freeze method, we must understand what happened, and how that shapes. So what type, if you want to use the chat feature right now, what types of events cause PTSD? And I'd love to just check that out real quick. What type, anything potentially? Well, I don't know about anything causing PTSD, but what types of events, incarceration, sexual or physical abuse, poverty, extreme poverty could definitely be perceived as a traumatic experience. Anything that causes harm. So this question's a little bit: violence, domestic violence, certainly all of those are traumas. It's a little tricky of a bit tricky of a question. Having to retell your story. We're gonna get to that later. I find that school trauma for neurodivergent children isn't brought up enough. I agree with that. It's a little bit of a trick question because PTSD is caused by memory and experience and changes within the central nervous system due to an experience that the individual has. So all traumas aren't equal. And, we have to be careful in saying, okay, a child was in a car accident, therefore he has PTSD or she has PTSD. You have to look at it as very subjective to the experience the person has. And there's epigenetic factors involved of how many traumas could lead to PTSD. But typically, the events that cause post-traumatic stress disorder are any event that could threaten one's physical safety, sexual safety, emotional safety, car wrecks, rape, interpersonal violence. sexual abuse, physical abuse, trafficking. All of those are classic examples, but like some commenters mentioned, extreme poverty could be certainly a traumatic experience in childhood that would likely be complex developmental trauma. I think that's really critical for us to acknowledge. We have a lot of parents, guys, here that come in and say things sometimes like, my kids were only neglected. Or, I've heard that from some CASAs before, like, well, my child that I'm working with wasn't physically abused and wasn't sexually abused, like the other kids that I've worked with. They were only neglected. And we got to be real careful with that, just like we had talked about what events cause PTSD, because trauma is trauma, and the brain doesn't differentiate between traumatizations. Abuse sends the message, I don't like you. Neglect sends the message, you don't exist. But nevertheless, both deeply impact the way that we feel, we trust, and we think. I try to tell all of my practitioners, if you've seen any of my presentations before, you've seen this slide, don't get caught in the vortex. Little Johnny is a 9-year-old male in a foster placement in Haywood County, Tennessee. He's been in 5 foster homes throughout the past 2 years. Little Johnny suffered physical and sexual abuse for 2 years prior to foster placement. And the foster parent gets really, really flustered and just overwhelmed and brings little Johnny to a psychiatrist and say, why does little Johnny hit, punch, kick, spit, and cuss me out? And why is this happening? And the psychiatrist says, oh, well, that's easy, Miss Smith. Little Johnny has ODD, oppositional defiant disorder. And Miss Smith, the foster parent, turns back and says, well, why does little Johnny have ODD, oppositional defiant disorder? Psychiatrist turns to her and says, that's easy because he hits, punches, kicks, spits, cusses you out, and he's just a bad kid, right? So you got to understand that some circular reasoning there. Why does little Johnny hit, punch, kick, and spit and go wild at home? Because he has ODD. Why does he have ODD? Because he hits, punches, kicks, and spits, and very little intrinsic value in the form of treatment, other than perhaps medication for that is going to be yielded. We have to understand, again, deeper, being a trauma-informed practitioner, is understanding that iceberg, understanding what little Johnny experienced at 5, 6, and 7, and understanding how that has shaped his central nervous system's fight, flight, or freeze responses in the current environment, because hitting, punching, kicking, spitting is what type of response? Fight response. And when I said all aggression that I see in kids is mostly rooted in fear responses, you fight, flight, or freeze when you are afraid, right? So that's something really critical for us to understand, because we can get wrapped up. And look, in my career, I've been wrapped up in the vortex in professional capacities before. So we have to always keep in mind, looking at this, putting on those trauma-informed glasses, what does this child experience and what does this behavior tell me about the child's needs? And that leads us to Dr. Purvis's, one of her famous quotes is, our kids are often caught between an amygdala and a hard place. And being able to understand this, again, creating a trauma-informed environment for me is critical in having that fundamental education of what is trauma and how it impacts the brain, because then we can reverse the effects. So again, some questions for you, and we can get to some of the responses towards the end, but some of the things to look at is, why is understanding neurochemistry vital in developing a trauma-informed approach? How can a view of a youth's behavioral patterns in terms of needs expressed and through a trauma-informed lens, how can you view a youth's behavioral patterns in terms of what is this behavior indicating the youth is in need of? And just like an infant, think about the needs of an infant, okay, at 6 months old and crying. Um, and that baby might need what? That baby might need a diaper change. That baby might need to be held. That baby might need to be rocked. That baby might need to be burped. That baby might need to be comforted with warmth if it's too cold. It might need to be cooled if it's too hot. There's all those needs expressed, right? Well, there's congruent needs with a 9-year-old or a 14-year-old. They just don't manifest in terms of maybe a diaper being changed, but the soothing, the calming, the comforting co-regulation need is absolutely present in those kids. And it's our job to figure out, is my child hungry? Is my child you know dehydrated? Is my child sensory seeking, or is my youth sensory defensive right now? How can I co-regulate sensory systems to calm? All of those, it's our responsibility. And looking at when a youth does engage in behavioral patterns that are challenging, what is the child's past saying about that? Not, oh, this kid's just a bad kid. We can't have him in class anymore. So with every child that comes through Hope House is going to know these two terms, amygdala and hippocampus. Very simply, your amygdala is your body's alarm system. It goes skyrocketing whenever you experience a traumatic event. Look, you're on the causeway yesterday, you're driving, dense fog, you start to become nervous, you start to become anxious. All of a sudden, bam, your taste, touch, sight, hear, and smell sensory systems go haywire in interpreting I'm in danger. Your amygdala goes to a 10 out of a 10. It floods your brain with sensory overload and neurotransmitters and stress hormones. So you're going to have excitatory neurotransmitters to keep you alert and keep you on edge to be able to survive, right? So you're going to have norepinephrine, epinephrine, which is also known as noradrenaline, adrenaline. You're going to have dopamine spikes. You're going to have cortisol, a stress hormone in your brain spike. And all of that is to get you to survive in that scenario. What do you think happened on the causeway? I'm just using that as an example. What do you think happened when the first car hit and every car behind it started to pile up and you're hearing every sound? Those people were certainly in an acute stress response to that stimuli within their environment, right? The hippocampus, the library, is storing all of that information. It's storing everything within your sensory experience: taste, touch, sight, hear, smell. So let's use our causeway example. What did someone smell? I smell rubber tires burning. I smell smoke. What did I feel? I felt intense pressure as I hit the steering wheel. What did I touch? What the experience of absorbing that. Let's not get too graphic on like taste. Did I taste what was in the air almost of the collision of the cars? Maybe if I got a cut on my head, I tasted blood on my face. Taste, touch, sight, hear, smell. I hear all of the sounds crashing. All of those sensory systems are active, telling my brain that I'm in danger. The hippocampus is your library, absorbing everything within your environment and almost telling your body, the next time I'm in the vehicle on the causeway, I need to be extra alert. Just like with kids here, the abuse happened in their bedroom. Child abuse, child sexual abuse happened in their bedroom. And I can no longer sleep and I can no longer go in that bedroom. My hippocampus has absorbed that this is a dangerous place and absorbed everything within that environment to keep us safe. This is another very common example that I use, and I'm from Tennessee. Originally, I moved here 7 years ago. But I did go to Nichols. I when I graduated high school in Tennessee, I went to Nichols and just fell in love with Louisiana. And then after graduating, moved back to Tennessee, and then this position opened up, and I was so excited to come to the North Shore. But in Tennessee, as opposed to Louisiana, we have an abundance of what animal? Bears, right? And if you're ever in East Tennessee, you might encounter a bear. They are not teddies. They are not calm, and they don't love you, and they're not like the Coca-Cola bears at Christmas time on the commercials. So please do not pet our native bears in East Tennessee, because I promise you they will attack you. Some of them are very aggressive. And I want you to imagine you move to East Tennessee, Knoxville area, Sevierville, and you're walking through the forest. And all of a sudden, you don't have your cell phone with you. All of a sudden, a giant, giant bear begins to attack you because it thinks that you're after its cub. What are you going to feel? What are you going to think? And what are you going to do? So just think about that for a minute. What are you going to think? What are you going to do? And what are you going to feel when that giant black bear begins to attack you? Run away. Okay. A lot of people think that they're going to think, man, that's a big bear. I better get out of here. And then I'm going to run away. Or they're going to think, oh man, that's a big bear. I'm going to pick up a stick and fight it. And they pick up a stick and fight the bear. Terrified, feel terrified. How do I get out of this alive? Brianna, I'm in danger, and try to recall any bear advice. That's a good one where you think, oh my goodness, I'm in danger. I better think about, what did they say in 6th grade in my fitness class? If you ever encounter a bear, it's to play dead, curl up in a fetal position, and then you're going to get in a fetal position and play dead. All of that is what we typically believe. We think we're going to feel afraid. We think that's a big bear, feel afraid, run. What actually happens is very, very different. We're going to watch a quick video that shows you why you shouldn't text and walk.
Walkway. Mark Kodo
Yeah, he's,
in
south on
Sky
Briggs.
5. Well, this is very interesting. Apparently, the Bears
Yeah,
decided
that's
to
right,
move around.
Oh, garbage cans are out too.
Yeah, just a couple of minutes ago, the bear left the clearing in the backyard there, and he made his way over to the driveway over on Mayfield. He came down that driveway, down Mayfield, and now he's on Briggs, and now it looks like he's turning into another driveway here. We're going to kind of maneuver around and see if we can get another shot of him. But yeah,
There's
he
a
would
person
definitely.
walking right there.
Oh,
okay, we
man.
got someone, a resident there.
He
Yeah.
just saw the bear. Oh,
I love how the newscasters, it's like a play-by-play for an NFL game. It's not a lot of empathy in their discussion. So what you saw right there in that moment, and what actually happens is your sensory systems in your cranial nerves absorb that there's a threat. It takes you about 15 milliseconds for your body to completely respond with a fight, flight, or freeze response. Your neurochemicals designed for survival, adrenaline, flood your brain, and your body kicks in with a series of physiologically adaptive survival responses. Your palms become sweaty, your blood vessels immediately constrict, your muscles become tense, your heart rate spikes, your brainwave activity spikes. All of those survival responses are designed to get you out and to keep you safe. Why do your blood vessels constrict in that situation? Because your body knows intrinsically that if that bear attacks you, you have less of a chance of bleeding out based on your blood vessels being constricted versus dilated, right? So our bodies keep us safe. And in any truly traumatic experience where your life is in danger, or you're physically, emotionally, sexually threatened, you're going to encounter that same fight, flight, or freeze response. And then you're going to process later, right? So you're going to sell your cabin, move back to Tennessee, move back to Louisiana, go to a Cracker Barrel and say, man, these biscuits are good. I'm never going back to Tennessee. Tennessee sucks. They have really dangerous things there. So why is all of this critical? To understand the physiological response happens first to survive, and then thoughts and emotions happen secondary. Why are we even talking about bears? Why is any of this smart to know or trauma informed? Because our kids are encountering those bears every weekend, every night, maybe once every other week. Those bears, the brain doesn't differentiate between bears and Uncle Tim, who is taking advantage of me and sexually assaulting me and telling me if I ever tell anyone, he's going to hurt me and my family. That is a bear to the brain. And the brain is interpreting that situation or domestic violence. When my dad drinks, my mother gets beat and he threatens to kill her. The brain isn't saying, oh, well, hold on now. This is humanity in the 21st century, and I'm no longer in the woods with the saber-toothed tiger, the jungle, and the saber-toothed tiger from 150,000 years ago. So all of that is to say that trauma typically impacts the brain in the same way. What we see with our kids with fight, flight, and freeze response, where they get stuck with that chronic trauma, or they get stuck with that complex developmental trauma, they start to fight by hitting, kicking, yelling, fleeing, by running away, distracting behavior, changing the subject. And then lastly, freezing examples, dissociation, melting down, whining, and most popular, zoning out. So we see, for those clinicians in the room, what do we often see with comorbidity with PTSD with kids is ADHD, because, oh, they're just checking out, they're checking out. Well, we have to see if that's a survival behavior that's happening, rather than diagnosing it and treating it with a amphetamine or a stimulant medication, if it can be treated first with a good therapeutic treatment regimen. So all of that is critical to help us understand the way that the needs behind the behavior, because we understand if our kids are in fight, flight, or freeze, with felt safety and calming and connection and co-regulation, we can bring them back to not being stuck in that fight, flight, or freeze methods. And that really is PTSD. Here's a couple of just brain imaging where you know that your frontal cortex is responsible for thoughts and processing and deductive reasoning and mathematics and language and language interpretation. So the prefrontal cortex with trauma victims that have chronic PTSD often becomes more inhibited, because the back part of the brain, which is your occipital cortex, your parietal cortex, are certainly more involved in being able to survive, having those basic functions. And your body is always going to prioritize survival over the ability to do mathematics, right? So it's I used to have a professor at Nichols, if any of you all went to Nichols, Dwight Boudreaux, and he would always say, yeah, I can't do a Cajun accent, I can try, but he would always say, guys, I'm trying to tap into your frontal cortex, I'm trying to tap into your prefrontal lobes. And what Dr. Boudreaux was eloquently stating is that he wanted us to think and be deductive reasoners. So that shows you, though, that through PET scans, you can actually see that trauma victims at times don't have the capacity to think through, if Billy punches me on the playground, instead of just hitting him back, I should go tell a teacher because I would get in trouble first. If you're stuck in that fight, flight, or freeze, it's very hard to think that way. And then just understanding that neurochemistry, neurochemicals called neurotransmitters that transmit messages between neurons are affected as well. And we talked about adrenaline, noradrenaline. Both of those are going to be flooded in the brain whenever traumatic events occur, chronic PTSD, and that can result in deficits, right? Because if you flood over excite one neurotransmitter, that could result in deficits in the future, kind of like someone who does cocaine all night is going to flood their brain with dopamine, and the next day is going to have a lack of dopamine, where you want it right there in the middle, in the interquintile range, rather than a deficit or overexcitation, which is going to cause significant behavioral challenges. So the bad news is that the brain is plastic and conforms to the environment. The good news is that the brain is plastic and conforms to the environment. So all of the trauma, the fear, the pain, the encountering of the bear every weekend for 2 years is certainly going to impact the central nervous system, and cause significant trajectory towards depression, anxiety, trauma-related disorders. But the good news is that felt safety, a sensory-rich environment, a supporting environment, and most importantly, an attuned caregiver to the child's needs is going to undo that. And it's going to rewire the brain in being able to just be a kid again and feel safe. And we know that through neurogenesis. So this is the final component, and just I'm going to give you some very simple proactive strategies in creating an environment rich in felt safety. I put a quote there. Whenever I was trained at TCU, after one of the 1.5 hour segments, it was we were in Fort Worth back in like 2012. And it was the practitioner component at TCU. I went up to Dr. Cross, and he had just given a lecture, and I said, "Hey man, I just want to let you know how cool this is. This is awesome. I love this model. You guys did a great job. What a great training, and thanks for sharing." And he looked at me like, I'll never forget it, like real solemn, like with no really affect, either up or down, and just said, "You don't need to thank me. I hope you understand you've been given a responsibility." And that always stuck with me because I'd never really been told like, "Hey, you're responsible." Not only is this just a training modality, it's actually more of a paradigm to truly empower healing and recovery. And that paradigm is TBRI, trust-based relational interventions. And it's based on the concept of attachment therapy. So felt safety to me is the cornerstone of healing from PTSD, and identified as what is felt safety. It's the ability to be regulated, to feel calm, and to not feel this sensory stress that I'm in danger. It's the feeling of knowing my needs are going to be met. It's the feeling of being valued and being surrounded with an environment that supports me as the child. Okay. Children who are safe don't necessarily feel safe. We get that a lot. So we have kids in foster care where the stepdad who abused them for 3 years and took pictures of them and created CSAM, is now locked up, right? And the kiddos in foster care, or the kiddos with mom who's supportive, and they're coming in and they're still stuck. They're caught in that chronic activation of the amygdala. And I want to really empower you to think, what helps kids feel safe? What helps them feel calm? It's not toys. It's not a new Pokemon action figure. It's not going to their favorite movie. It's certainly not playing on the cell phone. Okay. What helps kids feel safe is an attuned caregiver that values their needs and wishes to co-regulate with them and is non-critical, non-judgmental of their past trauma, but connected with how can I help you meet your needs? How can I give you voice? How can I empower you? The attachment research was founded through John Bowlby back in World War II. All of the really wealthy families sent their 4, 5, 6 kids to live in the countryside when the bombings were happening. And the families in lower or middle class would take their families every night, bomb alarms would go off, and they would rush them to the bomb shelter. And the theory was that the kids that were 120 miles north in the countryside would not be affected and not be traumatized because they weren't exposed to the bombings, right? And the kids that were in the bomb shelter that were exposed to all of the bombings and the sirens and the fear would be completely PTSD certified, full diagnostic criteria met, right? And the opposite happened. After the war, the kids got back into class and the behavioral challenges started to be noticed with the kids. The emotional challenges, the emotional dysregulation was relative to the children who were sent away to the countryside, and the kids who were rocked and held and comforted and calmed throughout that whole experience were relatively well stabilized and in the more the mean of calm and behavioral regulation. So that prompted a great amount of research that showed the attachment trauma of being separated at 2 years old from your family, your mother or your father, and being cared for by a nanny with 6 kids was actually more detrimental because there wasn't co-regulation, soothing, and attuned caregiving. And that's known as a cycle. And we need to understand this cycle. And being trauma informed, when an infant cries, he or she is experiencing distress. The sympathetic nervous system's activated, which is your amygdala, right? That we already identified, your alarm system. Those excitatory neurotransmitters are accelerated, adrenaline, noradrenaline, dopamine. Hey, I need help. I need help. I need my diaper changed. I need my to be held. I'm too hot. I'm too cold. Help, help, help. The caregiver comes, the caregiver meets that need, and what happens? The magic of calming, of proprioceptive sensory calming engagement. The child is comforted. The parasympathetic nervous system, the calming components of the nervous system, embrace that child in GABA and serotonin and your inhibitory neurotransmitters to calm and to relax and to counteract that excitatory state. And we see that. And thousands and thousands and thousands of times this happens in early childhood and early infancy. And the child learns, I can trust the environment around me, and I trust that the world is a safe place. When trauma happens, it disrupts this attachment cycle, or an attachment trauma, losing the ability to be cared for or never being cared for, and the child is stuck in that perpetual state of sympathetic hyperarousal, which we know our kids, it's the bear every single other day for a year, and then PTSD is at the forefront. And just understanding that attachment cycle, we have to, when you see needs met right here, we have to intervene. Even with a 12-year-old, we have to when they are in that distressed sympathetic nervous system and excitatory state, we have to figure out unique methodology to comfort, calm, and promote parasympathetic nervous system input. This is a great video from Tronic with Harvard University. I absolutely love it. And please watch it. It really shows exactly what I'm talking about with the ability, watch the ability for the parent to bring the child back and co-regulate. Let's see. Here we go.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's
Okay, I apologize. I'm not sure why that discontinued, but you can look up that video on YouTube. It's called the Tronic Still Face, and what it shows is when the caregiver comes back and is completely stoic towards the youth, towards the infant, the child will experience dysregulation, and then the caregiver will come back to be able to co-regulate that with that child. This is, look, if you have one slide that I really want you to take with you in understanding how to create a trauma-informed space, this would be it. And please understand that the most critical thing that you can do in creating a trauma-informed environment, whether it's in healthcare, judicial settings, schools, churches, offices, whatever, is getting informed, being trained, having that psychoeducation to understand some of the concepts that we've brought here today, and understanding that child's behavior through that lens, through not what's wrong with you, but what happened to you, right? Moving away from what's wrong with you. Knowledge is power. Mindfulness and introspection, always approaching that engagement with any child to understand my own history, right? What is my attachment history? How does this impact me if I hear a child screaming and crying? Does it activate my emotions where I might be biased in my response? Those are great questions. Do I need to look at myself introspectively, how I was raised? What was I raised in? An authoritarian Kim Jong-un dictatorship where you mess up and you're sent to your room with only a Bible for the next 5 hours, and and told that you can only come out when you apologize, and that sort of thing that we see kind of maybe a lot with some older generations too. If I'm raised from that environment, how does that history impact my ability to be present now with my youth? And mindfulness related to that lens too, and where they came from. How did they get to me? How can you empower when people talk to us about Hope House, they say, "Oh, I can never work there. That's so depressing and so terrible to work with abused children." And we're like, what are you talking about? Like, we have 500 brave, courageous survivors that fought like hell to get to us. And we have the privilege and the honor of being able to help them in their journeys of recovery. Like, think about what your children went through or what a trauma survivor went through to get to your setting, for you to be able to co-regulate with them. An adoptive parent, that child is coming home to you now, right? So that's a novel perspective in some cases. Creating a neutral, calming space. This is one CAC, and I'm not trying to, I think I misspelled Arnold, so apologize for that. I'm not trying to call out anybody. This is a CAC I went to down in Orlando, and what it's a little over the top. Obviously, Orlando affiliated with Disney, so hey, Disney wants to design the CAC. Sure, let them in. Disney World, they're great. Maybe not so much. That's very sensory stimulating. How can you create a trauma-informed environment that's a little bit more calm, relaxing? I took that picture recently, and we try to have a calm space that kids and families walk into that could be right for a 3-year-old or right for a 17-year-old. Notice you're not going to see any TVs. You're not going to see any iPads. You're not going to see video games, because we want to create sensory homeostasis or sensory stability. I'm not saying anything's wrong with like a TV in the waiting room. I just creating a calm, nurturing space where we're going to try to empower that caregiver to be present with his or her child. Connecting principles of TBRI. When we are engaging with kids, we're never going to get up and talk to them up here. Like, so I'm talking to a child and talking at them low. No, I'm going to get on their level, and I'm going to keep my shoulders matched with their shoulders as much as I can. I might use symbolic touch. I'm not going to actually touch any kiddo because I'm a therapist. I'm not a caregiver. I would train a caregiver to provide healthy touch, but I'm going to use eye contact, warm voice quality. I'm not going to say, "Hey, what's up? Glad you're here today." I'm going to say, "Hey, buddy, what's up? I'm glad I can hang out with you today. I look forward to working with you. What is your favorite thing that you'd like to do? Or tell me, would you like to go get a snack? Can you use good words? Can you use your good voice?" So I'm going to use words that are calming. I'm going to engage with warm voice quality, playful engagement, and not speak at kids. Try to avoid Gladys the lunch lady syndrome, which I just coined, where I just remember as a kid in public school, you would get the square pizza and you would have Gladys with her hairnet on, and she would just look at you and just like, "What do you want, kid? You want a piece of pizza or do you want a burger? You choose." That's like the opposite of where we're going. We're trying to get connected and just attuned to helping that child feel safe. Choices and compromises. At Hope House, we've created, we look for opportunities to create choices for our kids. Why? Because choices are empowering, and oftentimes they haven't had any choice. They haven't had any ability to use their voice. So we want to create opportunities for them to express their needs. We offer them, would you like to use this button jar? We call this Buttons for Bravery. If you want to, you can select any button from this drawer, which are all brand new buttons, and you can put it in this jar. And we want you to know you're not alone. And so the jar is just full with buttons, and they can see that they're not alone in this journey. The other elements, snacks, hydration. Every youth that comes in, "Hey buddy, would you like to come pick out a snack?" I don't bring a snack to them. I let them choose. I let them choose a healthy juice or water. That's really it's very intentful. It's very mindful to let them choose at any choice. At the end of their interview, after their interview, we let them select any teddy on the wall. We let them select what they would like to do in therapy when we're in therapy. Nothing here is forced. A forensic interview is a criminal investigation. Are those kids forced to talk about what they went through? Absolutely not. We tell them, you don't have to talk about what you experienced. If you don't want to, we can always come back to it. We would hope we would talk about it to be able to keep you safe and to be able to meet your needs, but we can always come back to it at a later time. Nothing is forced. Lastly, just sensory enrichment and sensory needs being met. Again, taste, touch, sight, hear, and smell are all sensory systems that are interpreted with your nervous system in 15 milliseconds. Well, it takes about 50 milliseconds for you to have a thought, a cognition, right? So your sensory systems are really interpreting the world around you. For a child who's been through tremendous amounts of trauma, those sensory systems are going to be looking out for danger within the environment. And they might express behaviors as being sensory seeking, where they're seeking sensory stimulation, or sensory defensive, where a tag in my clothing is causing me to be in a panicked response because it's causing me sensory defensiveness. How can we have a sensory environment that could meet the needs of our kids? You could create simple little skills like tangle therapy, fidget spinners, rice buckets, if they need it. You could have your staff trained in helping children co-regulate with sensory systems. Like, hey buddy, do you want to try, let's push the wall down together. Let's get up and let's try to push the wall down. I'm in another therapist's office, but using very simple little techniques like, hey buddy, if you have a child who's hypo aroused and not hyper aroused, understanding like, hey buddy, let's try to play a game real quick called catch the ball or whatever. I'm just making it up. Having that staff understand how to sensory meet the sensory needs of that child and having them present. Also, just like I said, healthy snacks and hydration, sensory activities every couple of hours, being able to co-regulate with our kids is so important. Like teaching them, not saying, here's a handout, go practice this exercise. That's not where we're going. We're trying to co-regulate in a trauma-informed space. And lastly is we use if we do correct behavior, we teach parents to use the ideal response model, which we're going to approach negative behavioral patterns or challenging behavioral patterns with an immediate, direct, efficient, action-based response that's leveled at the behavior and not the child. You're not a bad kid. You made a choice that wasn't good in this scenario, and let's try to do a redo. Let's try to do this again where you can make a better choice. Wow, I'm so proud of you. You did such a better job. Not go to your room for 4 hours and you lose your whatever it is. So that wraps up. I know that's a